another leader from a life science company, Theo Borgovan from, again, a tremendous company that's doing a lot on the cutting edge of what's going on within GSK. Theo, how are you and where are you?
Hi, doing well. Thanks very much. I'm currently in Massachusetts, so not far.
All right, outstanding. And again, let the audience know. Let's start off with a little bit about your background, about your journey and where you come from.
Sure. I was trained as a hem-oncologist and finished training not too long ago, about 2 years ago, but have always had a passion for the research side and, of course, for the digital tech field. And after training, I do still see patients in the clinical setting, but I've also bridged over to industry. So I also serve as a medical director for a big pharmaceutical company in the lung cancer space.
That's super impressive. And talk a little bit about value-based care, which is, again, the theme for today's symposium, and how it's affecting the clinic and from your perspective and where you're sitting.
Right. In the clinic, we, of course, we look for tech that helps us lower costs, lessen the time needed for patients, and all those things hopefully will translate to better outcomes. I can speak about the things that have failed in the clinic. So I think, unfortunately, that's sometimes the best way to figure out what works. So I think the technology really needs to be targeted to the patient population, number one. A lot of the oncology population, octogenarians, are older, and for reasonable reasons, they don't know how to use technology. This also applies to the clinical side. Older physicians don't know how to set up some of this technology. So ease of use is really important. It should ideally be a one-click thing and allow for remote access if something goes wrong. So I think that's the biggest step, is the software has to work and has to be easy to use. Allowing for real-time readings is also very important. We have a lot of metrics that come through on our side that are cross-section. So they give you a value at a section in time. We really need to be able to go back into the patient's day, perhaps the week, and look to see where those numbers have been earlier on. So that's really important for the data and software to allow us to look at readings in real time and across a span of time as well. And the third is, and perhaps I think something that others will agree on here, because I've heard it harped on a lot, is integration into legacy systems. This is really important. I think it was a big theme at the Investigator Summit last year as well. Technology that talks to EMRs and standard medical software is absolutely crucial. We don't want a technology that sits apart from those, because that just means we have to look at a completely different data set, and it adds additional work to try and put the whole picture together. So ideally, everything that can talk to each other is the goal. And the last one is accuracy. Of course, things have to be accurate, have to have quality inspection that's done already by the time it gets to the bedside. And I think the most common thing in this space is just natural language processing. A lot of the language processing we use to dictate our notes are just don't work well. So I think accuracy is the last thing I'll add there. Yep. So that's it from the clinic side, Stan.
No, that's a lot. Yeah, and I think people are really trying to put their brains around the value-based care system and where they're going to lock into it and how they're going to be successful in it. It's not something that's intuitive. It does take a little bit more thoughtfulness to understand. And along those lines, what kind of medical applications may benefit from this, from what you're seeing, and how is that going to work out?
Yeah, I think there's plenty. I'll just quickly dive into that question by introducing the same idea of having helpful, valuable, reliable digital tech enter the clinical trial world. So we think about how we can adapt these same ideas into running clinical trials, and modalities like that and software like that and applications like that are really important, especially, to me, for somebody that tries to straddle the clinical and big pharma world. So I think if we can develop software that helps us along each stage of the clinical trial path, it'll absolutely be, it'll be amazing. And you think about how this software can help with recruitment, with monitoring, with the analysis of the data. It's something that was probably not pioneered, but essentially really accelerated during the COVID pandemic. I think because things needed to be done quickly within the COVID time, they used a lot of this AI technology to really help streamline a lot of these trials. So when it comes to location, We want to pick locations where the eligible patients will be the highest. Oftentimes this means making predictions months in advance before the trial starts. And so we can use AI to create, what I like to call these predictive futures to help generate where we think that the disease will be most prevalent and where we should target our focus. And ultimately in the clinical trial space, that translates to less screen fails and faster recruitment. Another area in recruitment I think that is really difficult is allowing for more patients to be eligible for the trial. So if you think about all the other clinical applications I spoke about in regards to AI being used in the clinic, if we can adapt that to a recruitment standpoint, we can allow for patients that live in remote settings that can't afford to get to hospitals to come onto trials. And ultimately, I think that's important in health equality and in the diversity message that I think we're all pretty passionate about. In the monitoring standpoint, so after a trial begins, a lot of the work is done to monitor safety events and to clean the data. I think if we have digital tech and AI helping the medical monitors keep tally on a large number of patients, it would be a great application for this as the trial progresses. And then of course, in the end, you think about analysis. AI has already come into this space to an extent, but we use, I've used not in the big pharma world, but in the lab space, I've used AI to help me do regression analyses at the end of acquiring data and to help me see trends, to help me look at subpopulations. And then the last thing I'll mention is the radiology world. And I think we've heard a lot about digital tech being used and AI being used to help make diagnoses. For trials that are dependent on our overall response, we want to be absolutely certain that the data that comes in is accurate and true. And so AI can help us there too. So no specific example, but a huge example of how AI can come out of the clinic, enter the clinical trial space within the same value judgment and help us along every step of the clinical trial modality.
Yeah, that sounds really impressive. And it sounds like you guys are being very thoughtful about what you're doing. And obviously along that thoughtfulness, there's also got to be some recognition of limitations relative to implementing these sorts of technologies in value-based care and even implementing value-based care itself. Talk a little bit about some of the limitations to implementing value-based care.
Sure. Yeah, plenty of hurdles. The technology, number one, is the technology really has to translate to important endpoints. For example, at-home monitoring systems, I'll think of a patient with like congestive heart failure, for instance. The patient and the technology not only has to show that the patient feels better, but what the hospital and the regulatory agencies want to know is, does the technology lead to less admissions in the hospital, less readmissions when compared to standard of care? And I think this is where HITLAB is important and what all this innovation is important for. It keeps the innovation going, and ultimately we hope to compare it to standard of care with real world outcomes. So such tech has really not been subject to randomized clinical trials, probably for a lot of reasons, but this is important, I think, ultimately in its validity. And once that is done, and once we prove that it's true and equal or better to standard of care, perhaps that may help with reimbursement too. So I think that's a huge thing to think about in the end, is not only prove it works, but hopefully that'll incite insurance companies to increase reimbursement for such technology. And the second thing I'll tell you is maybe more of on a personal level is that we shouldn't pitch this technology as replacing anybody. I don't think the local radiologist wants to hear that we have a new AI technology so you can go somewhere else. It should really be an adjunct. And that goes back to my other point, which is think about the endpoints that are important and infuse this technology to what's already being done, and it should be an adjunct to what's already in place and make it better.
Any final words you want to impart on the audience as we wrap this up?
Yeah, I would say it's important for clinicians to always chime in when they are dealing with a new technology in the digital space, because you don't really understand the limitations of an application until you start to use it and you start to adapt it into your own daily life and to see how it meets your demands. So I think it's important to stay vocal and participate in forums such as this so that there can be a crosstalk between the clinical world and the tech world. I think those worlds need to be married for this to function.
Fantastic. Theo, thank you so much for joining